Hello, my name is Dr. Dermot Phelan. I'm Medical Director of Cardiovascular Imaging at Sanger Heart and Vascular Institute. And for the next 30 minutes or so, we're going to be focusing on stress echocardiography, theoretical and practical considerations, and trying to review this topic to give you some high-yield tips for the exam. To do so, I think we need to focus on the two main guideline documents regarding stress echocardiography. This one, Stress Echo in the Evaluation of Ischemic Heart Disease by Dr. Pellica, was published in 2020, and the Stress Echocardiogram in Non-Ischemic Heart Disease by Lanciolotti et al. Was published in 2017. I'd encourage you to review these documents prior to your examination, but we will go through a lot of the highlights over the course of the next 30 minutes. So I'm going to break this down into 4 sections. The first, we'll talk about the different types or modalities we have to do stress echocardiography and the issues with each of those. We'll talk about how to interpret a stress echocardiogram. We'll talk about the accuracy and prognosis, and then we'll talk about other things, the evaluation, the use of stress echocardiogram in the evaluation of patients who were not really concerned about ischemia. So let's focus on the different modalities first. So we obviously can do stress testing, we can do pharmacological testing or pacing. For exercise, we can use a bike, a treadmill. For pharmacological testing, we can use vasodilators or inotropes. And then for the treadmill and for the bike, we've got many different protocols we can use. Vasodilators, really, we're talking about using adenosine or dipyridamole. And for the inotropes, we're talking about dobutamine. But really, for most echocardiographic labs around the country, what we're talking about is exercise echo and dobutamine echo. And so the bulk of this talk is going to be focusing on those modalities. So let's look first at the different physiologic changes that occur with the different types of stress testing we can do. So for treadmill testing, we're trying to increase oxygen demand, and we see an increase in inotropy. We see a dramatic increase in heart rate with some increase in blood pressure, a drop in SVR, and an increase in venous return. For the supine bike, it's very similar. We tend to get a less robust heart rate response and a more robust blood pressure response because of this increase in venous return and contraction of the leg muscles. Dobutamine, we see a robust inotropy. There's also a vasodilatory effect, and so the blood pressure response is less robust. And for vasodilators, obviously, it's completely different type of stress test. We're not trying to increase oxygen demand, we're increasing coronary blood flow. And here we'll see a drop in blood pressure and a significant drop in SVR and venous return. So each of these types of stress tests are different in terms of physiology. And so for particular patients, we may decide to go with one test over another. When trying to decide what test to do, I think the main rule of thumb that we will usually recommend is that exercise whenever you can. This gives us a lot more information. It has the huge additional strength of giving us functional capacity data and hemodynamic response to exercise, which are very, very important from a prognostic perspective. Bicycle stress tests may be preferred for assessment of diastolic function or when we need to take imaging during testing. Dobutamine we mostly do when patients are unable to exercise, or if we're looking at viability, or if it's a test to look at patients who have low flow, low gradient aortic stenosis, while vasodilators are the preferred test for myocardial perfusion. So what about treadmill versus bicycle? And really, there's actually a big difference worldwide here, where we see more bicycle stress tests being done in Europe and more treadmills in the United States. With the treadmill, we are certainly more likely to attain a higher oxygen uptake and that peak heart rate there, but the person needs to be able to walk without holding on to the handrails. The big advantage of the bike is that we have a better quality ECG and blood pressure measurements. Very useful if the patient has orthopedic image limitations. And obviously, as I said before, the advantage is that we can image during exercise. This is kind of half in jest, but it's also true that Americans do not tend to ride bikes as much as Europeans, and that's one of the reasons we see that differential there. And if you're someone who's never or very, very rarely rides a bike and you're asked to do so for a stress test, oftentimes you'll end up finishing the study more because of leg fatigue than because of cardiovascular stress. So some practical considerations for treadmill exercise. We need to really get some very good resting images, recognize if we need to use ultrasound enhancing agents if we're not seeing the endocardium very well. We need to be able to have a patient who can move quickly from the treadmill to the imaging table. And we really want to try and get them into that same position as when they're resting. If they can breath hold, great. Most of the time they can't. But we really want to try and get those images within 1 to 2 minutes as quickly as possible in order to be able to get that kind of peak stress. Now, you will have cases where patients' heart rates will recover very quickly. They're usually people who are very fit, so their prognosis is good to begin with. But if you can get those images done within 120, 90 seconds, that's still a prognostic data. And again, we should really be focusing on image quality during that particular period of time after stress, and we can do the measurements offline afterwards. The most common protocol that we use is the Bruce protocol. This is a stage protocol where we're increasing gradient and speed at set intervals. But it may not be the best protocol for many individuals. And so I would encourage you to be flexible in what type of protocol you're running, and having a very good and strong exercise physiologist can help there. For the bicycle, as we said, the images are obtained prior to and during the exercise. Usually we start a workload at about 25 watts, and we'll increase this every 3 minutes. And we can, if we like, measure multiple, take images at each stage there. The standard imaging planes are the parasternal long, parasternal short, apical 4 and apical 2 chamber views. Later and more frequently, we now also include the apical 3 chamber view, although the image in the apical 3 can sometimes be oblique and is less reliable. And so we just have to be a little bit more careful. When we're displaying the images on a stress echocardiogram, the more cardiac cycles that we can obtain, the better, as that will improve the accuracy of interpretation. We usually, therefore, will have on the upper left-hand quadrant a resting image, and then ideally present 3 peak exercise images and be able to compare the wall motion segment by segment, frame by frame. For dobutamine, at low doses, less than 10 micrograms per kilogram per minute, we see this is primarily affecting the beta-2 adrenergic receptors, causing an inotropic effect. As we increase the dose of the dobutamine, we can have an additional beta-2 and alpha-1 effect, which is more of a chronotropic effect. The standard protocol is 3 minutes stages where we are continuously monitoring heart rate, ECG, and the blood pressure. We usually will start at about 5 micrograms per kilogram per minute, and we increase in stages, usually 10, 20, 30, up to 40 micrograms per kg per minute. We can use atropine to try and increase the heart rate or hand grip. It is often a good idea to begin the atropine at about 20 or 30 micrograms if you feel that you're probably not going to get heart rate with dobutamine alone. We will image at rest, at low dose, at high dose, and in recovery, and we will finish the test once we reach that 85% maximum age-predicted heart rate. So the presentation of the images is different than the treadmill exercise or the stress exercise. Here we're showing a resting image, we show a low dose, a pre-peak and peak, or in some cases a peak and recovery image there. And so we can see the differences of function at various doses of dobutamine infusion. Ultrasound enhancing agents should absolutely be used if we fail to see two or more contiguous segments or a coronary artery territory cannot be completely visualized. And this is FDA approved. We want to consider using a very low mechanical index, usually less than 0.3 or even less than 0.2, which will reduce signal from artifacts and background tissue and improve endocardial border definition, as we can see there. We need to know the contraindications to stress testing, and so we shouldn't be doing treadmill or exercise testing in people who have had unstable or complicated acute coronary syndrome, if they've got serious cardiac arrhythmias, significant resting hypertension, and the number to keep in mind is greater than 180 millimeters of mercury. If they've had an acute PE or pulmonary infarct, acute myocarditis or pericarditis, acute aortic dissection, or symptomatic severe aortic stenosis. For dobutamine, the contraindications include hemodynamically significant LVOT obstruction, as that will make it significantly worse, unstable or complicated acute coronary syndrome, serious arrhythmias, and again, severe systemic hypertension. For vasodilators, we don't want to do stress tests in people who've pronounced active bronchospastic airway disease, who have significant hypotension, or again, who have unstable, complicated coronary, acute coronary syndromes or serious cardiac arrhythmias. For the endpoints, particularly for treadmill or exercise, ideally, this should be symptom limited. That is going to maximize our sensitivity and specificity of the test. Many labs I see discontinuing the test as soon as the individual hits that 85% age predicted heart rate. But if you do that, that is going to decrease the sensitivity of the test. We can do that, of course, for dobutamine tests. So we're going to stop the test when we reach diagnostic endpoints where we either reach that workload or we see marked ECG positivity, obvious echo positivity, or severe chest pains. If there are patient asked to stop because of either intolerable symptoms or exhaustion, severe hypertension, and that's diagnosed as greater than 220 over 120 millimeters of mercury. Symptomatic hypotension or arrhythmias are also reasons to stop the test. And if we have got a obvious, very abnormal test there. Exercise testing is generally very safe. The rate of death less than 0.05 per 10,000 tests. This was a study looking at almost 15,000 patients from the Mayo Clinic, and overall complication rate, as you can see, very, very low, a little higher with the dobutamine, and these were mostly related to benign atrial arrhythmias. So let's move on to interpretation. I think it's really important, even though we're talking primarily today about the imaging findings, but a lot of the important information we get from a stress echocardiogram is how the patient responded clinically. Did they develop typical chest pain or symptoms? What was their hemodynamic response? How was their blood pressure, their heart rate during the exercise? Functional capacity is key, and there's been multiple studies published now in almost any pathology you can name, showing that functional capacity is one of the key determinants of prognosis. And then finally, we're going to look at the ECG and the imaging response to exercise. For the boards, it's extremely important that you know all of the segments of the heart. And so I won't go through this too much, but in the long axis view, we're cutting across the anteroseptum and the infralateral wall there. In the two-chamber view on the right side of the screen, we have the anterior, on the left, the inferior. And on the four-chamber view, we've got the infroseptum and the anterolateral view there. So really important that you know all of those segments. And once you do know that, then you have to piece that together with the segmental perfusion to define what you suspect, where you suspect the coronary disease is. In the exam, you will be given questions where there are obvious wall motion abnormalities, in particular coronary distributions, and you need to be able to recognize that. So here we see in green here the LAD, supplying the usually the apex, the apical septum, the anterior wall and the anteroseptum, the RCA, usually the mid and basal inferior wall and the basal infroseptum, and then the left circumflex or the RCA or the LAD will supply some of these additional walls here. I think it's important to know that our sensitivity of stress echo actually suffers a little bit like ECG in left circumflex distribution territories, because again, that ultrasound beam generally does not identify the lateral wall as well as the other wall. So just to be conscious of that. We do score the walls with at rest and with stress. And so if the wall is normal or hyperkinetic, either at rest or stress, we score that a 1. And so normally we're also looking at the thickening of the wall. We want to look at both the motion and the thickening. And so for normal thickening, that's usually greater than 50% of the end diastolic thickening compared to the end systolic thickening. A score of 2 denotes hypokinetic segments, and we refer to that as a reduced in thickening of about less than 40%. We give a score of 3 for akinetic or severely hypokinetic segments, and here we see no endocardial motion and absent or less than 10% wall thickening. A 4 indicates dyskinetic septum or dyskinetic motion, where it's an outward motion and the wall is thinned, and a 5 for aneurysmal, again, outward motion where wall thickening is absent or thinned. We use this scoring system then to create a wall motion score index. And basically, this is the sum of all the scores divided by the number of segments. So if you have a 1, which is normal for every segment, and then you divide it by the number of segments, that's 1. So a wall motion score index of 1 is normal. And you can see here in this study of over 1,500 patients who underwent stress echocardiograms, that if you have a wall motion score index of 1, your outcome is excellent. As your wall motion score index increases, your outcome does get worse. Key considerations for imaging, we really want to look at both endocardial motion and thickening, as we said before, and we need to be very careful of translational motion or tethering of the walls. We want to look at LV chamber size, both at rest and with stress, to look for transient ischemic dilation. We're going to look at each segment and by segment, and we'll do that analysis going frame by frame, particularly in early systole. We want to be careful of the basal inferior and basal septal segments, as they can be tethered by the fibrous annulus, particularly if there's mitral annular calcification or a mitral valve ring or prosthesis there, but there should be normal thickening. Remember, ischemia also causes a delay in onset of contraction known as tardokinesia, a decrease in the velocity in contraction, and post-systolic contraction, which we can often detect using strain. When we're doing our stress echo, we need to honestly comment on image quality and if the endocardial border was poor or there was off-axis imaging. So when we see a resting wall motion, it is either related to an infarct or scar, or this is a viable wall motion, and this is usually related to either acutely or chronically hypofunctional segments. And so this can either be broken down into stunned myocardium, and this is usually after an acute ischemic injury, and this will recover with time, or it's hibernating myocardium. And this is related to chronic ischemic injury and will recover with revascularization. So this is obviously very important to know, and we will use low-dose dobutamine stress echocardiograms to define whether the myocardium is scarred or whether there is viable myocardium there. And this does predict recovery after vascularization. So when we think about the wall motion during a dobutamine stress echo. If there is normal wall without ischemia, at low dose, it will increase. At peak, it will increase further. If there is scar, the wall motion will be akinetic and will not change either at low dose or peak. If it's ischemic, it may be normal or reduced at baseline. At low dose, that function will go down, and at peak, it will go down further. Uniphasic response is where we've got a hypokinetic or akinetic segment at rest, which improves at low dose and improves further at peak. And we're usually talking about cardiomyopathies. And then biphasic response is where you've got a hypokinetic segment at baseline, which improves at low dose, but then becomes ischemic and reduces at peak. And so here is where we'll see that viable myocardium. So what is considered a positive test for ischemia? Well, a new or worsening wall motion abnormality is really what we're looking for. And here you can see normal apical septum, and in someone who's got a LAD lesion, a reduction in that segment there. Additional concerning findings include transient LV dilation, a failure of the LV to improve its ejection fraction with stress, or worsening diastolic function. And remember, as we think of the ischemic cascade as exercise duration goes on, we'll get local ischemia, and diastolic function will precede regional systolic function, which will occur before ECG abnormalities or chest pain. So assessing diastolic function can be very useful. We'll do this using a combination of the mitral E velocity, the inflow, and the annular velocity, the E prime in the apical forechamber. We'll usually use this a little bit later in recovery. The heart rate needs to come down a little bit to avoid EA fusion. And if that E over E prime ratio increases above 14, that tells us that there's exercise-induced diastolic dysfunction. And this can be related to ischemia or maybe related to other myocardial disorders. And here's an example of a E over E prime of 6.5 at rest, which increases dramatically with stress. You know, most of our analysis, as we said, is based on visual assessment of wall thickening and wall excursion, but there are various techniques that we can try and quantify. These are all referred to in the guidelines. The reality is that none of these are standard practice just yet, and it's unlikely that you will be tested very extensively on this. Real-time myocardial contrast echo is really a very cool thing, a technique that we can use to identify issues with perfusion. Unfortunately, it's not used in very many labs. It's not FDA approved, and that is something important to recognize. Really, what we're trying to do is assess myocardial contrast replenishment after a high mechanical impulse. And so in a normal case, we should see replenishment within 4 seconds at rest and 2 seconds with stress. And so here's an example from the guidelines. This is before the mechanical index flash. Then after the flash, the bubbles are destroyed, the myocardium looks dark. Within 1 second, we see replenishment at rest, but with stress, we do not see replenishment here in the lateral, infralateral apical segments there. Right ventricular assessment is important, and we do see a decline in TAPSE if there is proximal RCA obstruction. However, we need to be careful that this is less reliable in patients who have had dobutamine stress echoes. And also, we need to recognize that RV dilation and reduction function can be related to multivessel disease or exercise-induced pulmonary hypertension. Stress echocardiogram is accurate and specific. It's more accurate and specific than stress ECG, and the sensitivity is comparable to perfusion stress testing or nuclear stress testing, and the specificity is probably a little bit better. Again, the sensitivity improves with multivessel rather than single vessel disease. We need to be aware of things that will cause false positive stress echocardiograms, and these include cardiomyopathies, where you can have small vessel disease or local wall motion abnormalities, abnormal septal motion, a hypertensive response to exercise, coronary vasospasm or microvascular disease, that basal inferior segment we mentioned before, and if there's significant MAC or mitral valve replacement. False negative studies can occur if there's delayed image acquisition, or it's a submaximal test, or poor image quality, or if there's collateral vessels or the patient is actually taking anti-anginal therapies. So we tell these patients to not take their beta blockers or other anti-anginals before their stress testing. A normal stress test is considered normal if there's normal wall motion, a decrease in volume, an improvement in LVEF, an average or greater functional capacity. And if you achieve all of that, you can see that here a good workload, your prognosis is really excellent. Your event rate is probably about 0.9% per year, not far off the general population. If you have a single vessel abnormality, your prognosis is worse versus multi-vessel. And if this is an LAD lesion wall motion abnormality, your prognosis is worse than an RCA or left circumflex disease. Important to recognize the prognostic markers, and these will be examined in your test. Again, a wall motion score index of 1 is excellent and has very good prognosis. Ejection fraction at rest and with stress going reduction in ejection fraction at rest or stress is a bad prognostic marker. The extent and severity, in other words, the number of segments that are ischemic, if there's transient ischemic dilation, a poor functional capacity, the early heart rate, the early ischemia at a low heart rate or ischemic threshold are all poor prognostic features. Heart rate response and the ST segment response and the Duke treadmill score is obviously something that I've put in here because it's possible to be examined. But really, the most robust prognostic markers are this wall motion score index and ejection fraction. So let's talk about what we can do beyond ischemia. And really, this falls into diastolic stress echo, assessment of valve disease, cardiomyopathies, and others, such as pulmonary hypertension, athlete's heart, and congenital heart disease. But for most of the time, we're really going to be focusing on valve disease and cardiomyopathies. So we use stress testing in valve disease really for 3 reasons. First is if there's severe disease, but the patient denies symptoms. So we're trying to see, do they actually have symptoms, and give an objective measure of functional capacity. The second is if the resting echo shows non-severe valve disease, but the patient has typical symptoms. So we want to assess the exercise hemodynamics in that case. And then the last case is in low flow state. It's really important in this context to discuss beforehand with the ordering physician what is the question at hand for that particular patient. Obviously, if it's coronary disease, we're going to be assessing segmental wall motion first. But if there's severe regurgitant lesions, oftentimes we're not going to be looking at the valve lesion itself. We're going to be looking at the LV global response for hemodynamics. If it's moderate mitral regurgitation with symptoms, we're going to be looking at that mitral regurgitation followed by the tricuspid regurgitation, looking at the estimated pulmonary pressures, and then the LV response. We want to see if that MR gets worse. Similarly, with moderate mitral stenosis with symptoms, we're going to be looking at those mitral gradients first, followed by assessment of TR. If it's low flow, low gradient AS, we're going to be checking the LVOT with pulse wave and continuous wave. And if it's hypertrophic cardiomyopathy, where we're looking for obstruction, we're going to want to look at that LVOT with 2D and Doppler and do continuous wave there to look for systolic anterior motion. So again, each of these stress tests need to be planned out carefully beforehand to make sure we're answering questions. As you know, there have been recent guidelines published in 2021 looking at the management of valve disease. And we can see that exercise testing in asymptomatic with patients with severe AS has a 2A indication. But if the patient is symptomatic, this is a 3, can cause harm. If the patient is symptomatic, severe aortic stenosis, we should not stress them. If they have low flow, low gradient AS, we should consider a dobutamine stress echocardiogram. For adults who have severe high gradient AS and symptoms either at rest or with stress testing, then an AVR is indicated. And in people who are asymptomatic with severe AS, if they have a drop in their blood pressure by greater than 10 millimeters of mercury, or they have a reduction in the functional capacity, this again is an indication for aortic valve replacement. So the bottom line is our stress testing informs our management of these people. So in summary, if they have no symptoms, we're going to use stress testing to prove they have symptoms. And if they have no symptoms, we're also going to go ahead with an AVR if we see a drop in blood pressure or reduction in exercise capacity. Now, we also get additional prognostic information from stress echoes or from any type of exercise test. We can see if we look at the predicted METs here, if people have greater than 85% of the predicted METs, whether they go for an AVR or not, compared to lower than 85% of the predicted METs, they have a much better outcome. Other worse prognostic findings are an increase with stress in the mean gradient of greater than 20 millimeters of mercury, a failure of LVEF to increase, or an increase in pulmonary hypertension. We're going to be talking a lot in future studies or future talks about how to evaluate low flow, low gradient aortic stenosis. So I'm not going to belabor the point here. We do see this in about 5 to 10% of patients with severe aortic stenosis who we see a low gradient but a low aortic valve area and a low stroke volume. And so using a dobutamine stress echo, we can define whether they have normal LV reserve, defined as a greater than 20% increase in their stroke volume. And if the valve doesn't open and the gradient goes up, they've true severe AS. If the valve opens and the gradient doesn't go up, it's pseudo severe. If they don't have flow reserve, then we're going to have to do some more testing to try and define. We can do a projected aortic valve area or assess their coronary artery or coronary calcium of the aortic valve. Aortic regurgitation, obviously symptoms denotes a bad prognosis. And so again, like severe asymptomatic aortic stenosis, if they're asymptomatic, it's reasonable to confirm that status. But we're not going to be trying to evaluate the aortic regurgitation at peak exercise, because remember, we're really shortening that diastolic period and the AR may look a lot worse or a lot less with stress. Additional prognostic information is in assessing the contractile reserve, the longitudinal strain, and TAPSE. For mitral stenosis, this is a 65-year-old female with shortness of breath, typical rheumatic valve. Her mean gradient is 5, her mitral valve area is 1.7, so she is moderate assessment of mitral stenosis, but she's symptomatic. And so in this case, this is a class 1 indication to do a stress test. And here we're going to first of all measure the gradients across this. And if our mean gradient goes above 15, this is a class 2B indication to consider balloon valvuloplasty. So again, we're going to use the stress test to prove that the patient is asymptomatic. And if that gradient goes up significantly, we're going to consider a balloon valvuloplasty. Mitral regurgitation is very load dependent and can increase with exercise. So in patients who have primary MR, where it does not seem very severe, but they do have symptoms, we should do a stress test, or vice versa. If it seems severe and they don't have symptoms, we'll also want to do a stress test. Poor prognostic findings, or if the MR increases by greater than 1 grade, if there's poor contractile reserve, if we have a greater than 2% increment in longitudinal strain, this dynamic pulmonary hypertension or the exercise TAPSE goes down. Exercise stress echo is also indicated for secondary MR if we see that the symptoms are out of proportion to the MR at rest, if there's recurrent acute pulmonary edema, or if the patient is going for CABG. So, the stress echo can really inform timing for surgery. If a patient is asymptomatic with severe primary MR, it tells us that we can still go for surgery, but we can actually see in this particular study where they delayed surgery for greater than a year in patients who had achieved greater than 100% of the predicted exercise capacity. They actually did not have a worse prognosis. So this is important when we're talking to those asymptomatic severe mitral regurgitation patients who have high functional capacity. Finally, for hypertrophic cardiomyopathy, it's important to emphasize that exercise echo is safe. This is a patient who has moderate SAM at rest, but we must remember that a third of patients will obstruct only with provocation. And so we should do stress echo on those patients who have symptoms with an LVOT gradient of less than 50 at rest, or with bedside provocative maneuvers. And we can often see this where they develop severe systolic anterior motion of the mitral valve and very high gradients. And this will dictate whether a patient goes for surgery or how we will manage them going forward. Stress echoes give us a lot of prognostic information for patients with hypertrophic cardiomyopathy. If they poor functional capacity, an abnormal blood pressure response to stress, severe increase in LVOT obstruction, or new wall motion abnormality. But once again, if we see patients with HCM who've got greater than 100% of their predicted functional capacity, their outcomes are excellent. So I hope you do very well in your board exams on stress echo. We've tried to cover over the course of the talk these kind of high yield questions. We didn't go through any cases, but I would encourage you to go to your lab and practice as many wall motion cases as you can, because they will certainly come up in your test. Thank you very much.